Today, we're not just looking at what your medication does, but we're putting on our lab coats, shrinking down, and following that tiny little drug molecule on its most important journey. We're talking about the moment it enters your body until the very moment it leaves.
And this isn't some, abstract biological concept.
No, not at all. This is the fundamental process that dictates if your medication works, how long it lasts, and precisely what dose your doctor prescribed. We're diving headfirst into pharmacokinetics.
Right. And for anyone who's not familiar with the term, pharmacokinetics is often it's boiled down to 4 letters, ADME.
ADME.
Exactly. It's the quantitative study of drug movement in, through, and out of the body. So you might have heard of pharmacodynamics.
That's what the drug does to the body.
Precisely. We're flipping that on its head. Today is all about what the body does to the drug.
And our mission, really, is to unpack every single step of this journey, revealing all the hidden chemical hurdles and biological systems that govern every prescription you take.
And that mission is, well, it's vital because this journey is the ultimate determinant of a drug's performance. Pharmacokinetics is the connective tissue, linking the total amount of drug you swallow or inject to the concentration of that drug where it needs to act.
At the site of action.
At the site of action. So the whole conceptual framework is built around that 4-step acronym: absorption, distribution, biotransformation, which we usually just call metabolism, and excretion.
Okay, let's try to visualize this flow for a minute. Imagine it's, I don't know, a river journey.
Good analogy.
The drug starts in its dosage form, that pill you take. It first has to break down, right? That's release. Then it has to dissolve into the river water, the solution. And then it hits the first massive dam, absorption, getting into the main circulation of the bloodstream.
And once it's in the blood, that drug is in constant flux. It's in this critical equilibrium. Some of it is tied up, what we call the protein-bound drug, and some of it is actively free.
And it's only the free drug that can actually do anything, right?
It's only the free drug that is truly useful. That free molecule then begins a race. It either moves out toward distribution, heading for the site of action, or maybe storage tissues.
Or it gets captured.
Or it's captured by the chemical cleanup crew for biotransformation, turning it into metabolites. And then finally, it's sent out via excretion, typically through the kidneys or the bile. It's a beautifully orchestrated, incredibly complex life cycle.
But before we even get into the ADME steps, we have to talk about the physical terrain. Because every single part of this journey, getting absorbed, distributing to the brain, getting secreted by the kidney, it all involves crossing the body's fundamental barrier.
The biological membrane.
And this membrane is not a welcome mat.
Far from it. Think of it more like a high-security wall. It's essential for keeping cells intact and functional. Structurally, it's a bilayer, maybe about 10 nanometers thick, or 100 angstroms made of phospholipids and cholesterol.
And the design is what's really key here.
The design is everything. You have these nonpolar, fatty hydrocarbon chains embedded in the middle, while the polar, water-loving groups face the watery environment on the inside and outside of the cell.
So why does that chemical structure matter so much for our drug?
Because that fatty, nonpolar interior gives the membrane 2 defining characteristics: high electrical resistance, and it's basically impermeable to anything that isn't fat-soluble.
So it's a bouncer that only likes fats.
Exactly. If your drug is large, if it's heavily charged, ionized, or highly water-soluble, it cannot simply squeeze through that fatty wall. It will be stuck.
And this is why drug design, the actual chemistry of the molecule, has to be fundamentally lipid-focused.
It has to be, just to ensure any chance of efficacy.
Okay, that sets the stage perfectly for absorption, the A. This is the drug's movement from wherever we put it, the mouth, a muscle, under the skin, into the general circulation.
But absorption isn't just a simple pass-fail test, We care about 2 distinct things here.
The speed and the quantity.
Exactly. The rate of absorption, how fast it gets in, and the total quantity, which we call the fraction or extent of the dose that makes it into the bloodstream unchanged.
And I think it's critical to point out that if you're getting a drug intravenously, an IV,
you skip this step entirely. Absorption is bypassed. You start at 100% bioavailability instantly. But for every other route, that drug has to cross at least one biological membrane.
Meaning it has to play by those strict fatty wall rules we just laid out.
It have no choice.
Okay, so let's unpack the factors that dictate whether absorption is a success, and let's focus on the oral route, because that's where most of the complexity is.
And it's where you, the patient, can actually influence things. We're talking about basic chemistry that can completely derail a treatment plan.
So what's the first hurdle?
The first factor is, well, it's non-negotiable: aqueous solubility. A drug in a solid form, like a tablet, has to first dissolve in the gastrointestinal fluids before a single molecule can be absorbed.
If it doesn't dissolve, it can't be absorbed.
Period.
Can you give us a real-world example of a drug that has trouble with this?
Absolutely. Think of some of the poorly soluble antifungal drugs, like grisafulvin or another one called ketoconazole. Their overall rate of absorption is entirely bottlenecked by how fast they can dissolve.
And for ketoconazole, this is a major clinical problem.
A huge one. It requires a very acidic environment, specifically gastric acid, low pH, to properly dissolve. So if a patient is taking antacids or a proton pump inhibitor to suppress stomach acid,
They're basically destroying their ability to absorb the drug.
you've got it. They are fundamentally destroying their ability to absorb ketoconazole effectively. It's a perfect example of how one treatment interferes with the fundamental chemistry needed for another.
Wow. Okay, so assuming the drug is dissolved, the next factor is concentration.
Right. Since a lot of absorption happens through passive diffusion, like perfumes spreading in a room, it depends entirely on the concentration gradient.
Higher concentration on one side, lower on the other, so it moves across.
And a higher gradient means faster movement. This is why a drug given in a highly concentrated solution is usually absorbed faster than a dilute one. But the system does have limits. If the blood flow isn't keeping up, that gradient will collapse and absorption just slows down.
Which brings us to surface area and the bloodstream. The area of the absorbing surface is a huge one.
Oh, it's paramount. It's the difference between drinking through a thin straw versus a giant bucket. The small intestine is the major absorbing site.
Not the stomach.
Not the stomach. And it's not because it's the most acidic or anything, the stomach wins there, but because of its sheer size. Thanks to all its folds and the villi and the microvilli, the surface area of the small intestine is enormous, hundreds of square meters.
Which just massively accelerates the absorption rate compared to the stomach.
Vastly.
And to keep that rate high, you need the vascularity, the blood flow, to act as an exit route.
Exactly. If the blood flow is poor, the drug concentration at the absorption site quickly balances out with the concentration in the nearby blood. That equilibrium just kills the concentration gradient.
So you need the blood to act like a vacuum cleaner.
That's a great way to put it. Rich blood flow constantly whisks the absorbed drug away, maintaining a low concentration on the blood side, ensuring that passive diffusion just keeps on going.
Okay, now let's talk about the chemistry barriers in the GI tract itself. We said the gut lining is lipoidal, fatty. So what's the Goldilocks zone for a drug to get across?
The drug needs to be two things: lipid-soluble and non-ionized. The non-ionized form of a drug is its fat-soluble form. So highly lipophilic drugs like ethanol or a muscle relaxant like atropine, they cross easily. Their absorption rates are almost perfectly proportional to their fat-to-water solubility ratio.
And this is where the complexity of pH and ion trapping comes into play, because the pH of your GI tract is all over the place.
It's wildly different. The stomach is highly acidic, pH 1 to 3. The small intestine is less so, maybe pH 5 to 7. And this drastically affects how much of a drug is in that non-ionized, ready-to-cross state.
So let's take an acidic drug like aspirin.
Right, a salicylate. In the acidic gastric juice of the stomach, a pretty big fraction of these drugs is non-ionized, so theoretically they should be absorbed well in the stomach.
But they're not.
Mostly not. Because of the immensely larger surface area of the small intestine, the majority of absorption still happens there. Even if the drug is a little more ionized, it just shows how dominant that surface area factor is.
And what about basic drugs like morphine?
It's the opposite story. A basic drug like morphine or quinine is highly ionized in the stomach's acid, so their absorption is severely hindered until they get down to the less acidic small intestine.
And let's not forget the dinner table. The food paradox is a massive variable in all of this.
A huge one. Generally, food is a speed bump. It dilutes the drug, it slows gastric emptying so the drug just sits in the stomach longer, and it can physically block absorption.
But you said a paradox, so there's an exception.
There is. And it's for those highly lipophilic, fat-loving drugs, grisafulvin, the antifungal, or lumefantrine, an antimalarial. They actually absorb better when you take them with a fatty meal.
Why is that?
Because the fatty meal triggers your body to release bile salts. And bile salts act like natural detergents, helping to dissolve and transport those fat-loving drugs across the membrane.
So take with food can be a very specific pharmacokinetic instruction, not just a suggestion to avoid an upset stomach.
Absolutely. And there's the flip side, too. Certain foods or supplements can actively destroy absorption by forming complexes.
Right. The classic example is tetracyclines with milk.
The most famous one, Tetracycline antibiotics will chelate, they form a complex with the calcium ions in milk or supplements. This complex is poorly absorbed, so you're basically binding up the drug in your gut and flushing it out before it ever reaches your bloodstream.
And finally, there's the body's own active rejection system. We have to talk about the cell's internal bouncer, the efflux pump, P-glycoprotein, or PGP.
PGP is fascinating and frankly a nightmare for drug developers. It's located right there in the gut epithelium, among other places like the blood-brain barrier, and its job, well, we think it evolved to protect us from natural toxins in food.
Its job is to recognize certain drug molecules and just throw them back out.
That's exactly what it does. It actively recognizes certain drugs' PGP substrates, like the heart medication digoxin or the immunosuppressant cyclosporine, and immediately pumps them back out of the cell and into the intestinal lumen.
So the body has a system whose only job is to actively reject medicine we swallow.
Precisely. It's a molecular defense mechanism. And this active expulsion dramatically reduces the concentration of the drug that's available to get into the systemic circulation, which significantly lowers its oral bioavailability.
And if someone has a very active PGP pump,
That person might need a much higher dose or a completely different route of administration just to compensate for the pump actively throwing the drug away.
this brings us perfectly to the core metric of this whole section, bioavailability, which we call F. It's the metric that defines the rate and the extent of the unchanged drug that actually reaches the systemic circulation.
And when you take a pill, F is almost never 100%.
Right. If we look at a graph of plasma concentration over time, bioavailability really tells the story of the drug's performance.
It does. Imagine plotting the drug level in your blood. Ideally, you want that curve to rise quickly above the minimum effective concentration, the MEC, and stay below the minimum toxic concentration, the MTC.
That sweet spot is the therapeutic window.
That's the window. So if you compare 3 different formulations of the same drug, one might rise too slowly. It might have the right extent, meaning the total amount absorbed is okay, but the rate is so slow it never actually crosses that MEC line.
So it fails clinically. It just doesn't work.
Exactly. Another formulation might be perfect, right in the window, but a third one might have such a fast absorption rate that the concentration shoots immediately above the MTC, causing toxicity before the body even has a chance to clear it.
So bioavailability is a balancing act between the rate and the total fraction absorbed.
It is. And the main reasons F is often compromised are things we've talked about: incomplete absorption, PGP activity, and, crucially, first-pass metabolism in the intestinal wall and liver. We'll come back to that one, but it's a huge filter.
This leads right into the regulatory concept of bioequivalence.
Yes. When a generic manufacturer creates a version of a branded drug, they have to prove 2 things: chemical equivalence, same ingredients, but also bioequivalence.
Meaning their generic version has to produce a plasma curve that is statistically identical in both rate and extent of absorption to the original brand name drug.
They have to be superimposable. It's especially important for drugs with very narrow therapeutic windows, like digoxin or the seizure medication phenytoin.
Because if the generic is even slightly different in its absorption rate, it could lead to either clinical failure or, poisoning.
Absolutely. The stakes are very high.
Okay. The drug has crossed the gate, it's survived the first pass filter, and it is now flowing in the blood. Step 2, distribution. The D. This is where the drug leaves the bloodstream to seek out its site of action, or maybe a storage facility.
And distribution is governed by several powerful forces. We already know about lipid solubility and the drug's ionization status. It's pKa.
Right.
But we also have to consider how much it binds to plasma and tissue proteins, whether there are any specialized tissue-specific transporters, and maybe most critically, regional blood flow.
Meaning the organs that get the most blood get the drug first.
The liver, the brain, the kidneys, they get the highest concentration of the drug, and they get it fastest.
Let's nail down what is probably the single most important concept in distribution: the free drug versus bound drug equilibrium. Why is the bound drug basically inert?
Well, your blood is full of these large circulating proteins, primarily one called albumin. Many drug molecules have an affinity for these proteins, and they stick to them.
And that drug-protein complex is now huge.
It's too large to pass through capillary walls. It's too large to be filtered by the kidney. So the bound drug is pharmacologically inert. It can't reach its site of action, and it can't be eliminated.
So binding acts like a temporary inactive reservoir. It holds the drug in the plasma and then slowly releases it back as the free drug gets used up or eliminated.
Exactly. It can sustain the drug's action over time. The amount of free drug dictates everything. And this leads us directly to a concept called the apparent volume of distribution.
The apparent volume of distribution, or V. Now, this sounds abstract. Why do we use a hypothetical or apparent volume rather than a literal one?
Because V is a theoretical parameter. It's a calculation that simply relates the amount of drug we put into the body to the concentration we then measure in the plasma. So if you inject 1,000 milligrams of a drug and the plasma concentration you measure is 50 milligrams per liter, V is 20 liters.
Okay, 20 liters. That's roughly the body's total vascular volume, which means the drug mostly stayed in the blood.
Right. But what happens if V is huge, say 500 liters, which is obviously way more than the total volume of your body?
What does that mean?
A large V means that after you gave the dose, the drug essentially vanished from the plasma. It's been sequestered deep within extravascular tissues. It has a strong affinity for fat or muscle or other storage sites. This is the case for drugs like digoxin, which binds extensively to muscle protein.
And the clinical implication of a huge V is pretty profound.
It is. If a drug is highly sequestered in tissues, it is nearly impossible to pull it back out using something like hemodialysis if there's an overdose.
You just can't get to it.
You can't reach it. Conversely, drugs with a low V, like warfarin, are highly confined to the plasma because they are so extremely protein-bound, sometimes 99% or more. They're easier to remove because the drug is where the filter can actually get to it. V is basically a quick way for a toxicologist to know if active removal is even an option.
Okay, let's talk about the literal walls the drug encounters, the biological barriers that restrict distribution.
The most famous of these is the blood-brain barrier, or BBB.
Right.
Unlike the leaky, porous capillaries you find in your muscles, the BBB is formed by extremely tight junctions between the capillary endothelial cells. And on top of that, glial cells surround these capillaries, creating these large insulating spaces. The whole structure is designed to be incredibly selective.
So what does that mean for our drug?
It means that non-lipid soluble and ionized drugs like most antibiotics, say streptomycin, or drugs like neostigmine, are completely shut out. They simply cannot pass that tight lipoidal seal.
So to get into the brain, the drug has to be really lipid soluble.
Or it has to cheat. It has to use specific, specialized active transporters like the OATP family to get escorted across.
The clinical need to understand the BBB is perfectly illustrated by Parkinson's disease.
Oh, absolutely. Parkinson's is caused by a deficiency of the neurotransmitter dopamine in the brain. But if you just inject dopamine, it's ionized, it's not lipid soluble, the BBB rejects it completely.
It's useless.
Useless. So the workaround is brilliant. We administer levodopa. Levodopa is the immediate metabolic precursor to dopamine, and it can cross the BBB using existing amino acid transporters. Once it's inside the brain, it's quickly metabolized into active dopamine. It's pharmacokinetics, literally finding a back door.
We also have to mention the placental barrier.
The placental barrier is primarily lipoidal, structurally similar to other membranes. And the critical takeaway here is that it is not a foolproof barrier.
It's not a wall.
It's not. While there are efflux transporters like PGP present, which offer some protection by pumping drugs back into the maternal circulation, any highly lipophilic drug, and that's most drugs used systemically, will pass relatively freely to the fetus.
So we have to assume the fetus is being exposed.
We must regard the fetus as being exposed to virtually all maternal medications.
Let's circle back to the blood and the dangers of competitive binding.
Yeah.
Plasma protein binding interactions. This is where things can get really clinically relevant and very dangerous.
For sure. We identified the binding sites earlier. Acidic drugs, like the blood thinner warfarin and the anticonvulsant phenytoin, they primarily bind to albumin. Basic drugs, like the local anesthetic lidocaine, they tend to bind to another protein called alpha-1 acid glycoprotein.
So let's imagine a scenario where two drugs are competing for the same binding site on albumin. Let's use warfarin as our example, a drug with a famously narrow therapeutic index.
The difference between a therapeutic effect and a fatal toxicity is tiny with warfarin.
Right, and warfarin is roughly 99% bound in the plasma.
Meaning only 1% of the drug is free and active.
Now suppose a patient starts taking a new drug, maybe phenytoin, which also loves to bind to albumin. The phenytoin might displace just a small fraction of the bound warfarin.
Let's say it knocks off another 1%.
So what happens when 2% of the warfarin becomes free instead of 1%?
That is a 100% increase in the concentration of active free warfarin. The patient has essentially doubled their effective dose instantaneously.
And because warfarin is an anticoagulant, that could lead to a massive bleed.
It can lead to severe, potentially fatal hemorrhage. This displacement interaction is one of the most clinically watched drug interactions in all of medicine. It just underscores why protein binding isn't a static number. It's a dynamic, critical factor in clinical safety.
Beyond the bloodstream, drugs are also prone to tissue storage and sequestration. They hide out in different tissues based on their chemistry.
You see this specialization everywhere. Digoxin, for example, is famous for binding strongly to muscle proteins in skeletal muscle and the heart itself. That's a big part of why it has such a large volume of distribution.
And tetracyclines.
Tetracyclines, the antibiotics, they have an affinity for calcium and magnesium. So they bind to the mucopolysaccharides and hydroxymepatite found in bone and teeth.
Which is why we don't give them to young children, correct?
Precisely. Because they concentrate in newly forming bone and teeth, they can lead to permanent discoloration yellowing and potentially affect bone growth. Other drugs, like the antimalarial chloroquine, concentrate heavily in the retina and brain by binding to nuclear proteins.
And then there's adipose tissue, all that fat.
It acts as the ultimate long-term storage facility for highly lipophilic drugs. Thiopentone, a classic general anesthetic, is extremely fat-soluble, so are environmental pollutants like DDT. These drugs just dissolve into the neutral fat.
And because fat has poor blood supply.
Very poor compared to the brain or liver. So the drug is released back into the circulation very, very slowly.
This slow release leads to the crucial phenomenon of redistribution. Let's use thiopentone as the perfect example here.
It's the classic case. When thiopentone is injected, it's so fat-soluble that it immediately rushes to the most highly perfused, lipid-rich organs, the brain and the heart.
This rapid influx into the brain causes the immediate onset of anesthesia. The patient is out in seconds.
Within seconds. But then, within minutes, the concentration gradient changes. The drug rapidly flows out of the brain and into less perfused, bulkier tissues like muscle, and eventually into fat.
So the patient wakes up, not because the body cleared the drug, but because the drug left the brain and redistributed somewhere else.
That is exactly right. The anesthetic effect terminates because the drug redistributed. But the drug is still physically present in the body, slowly leaching out of those fat stores for hours and hours.
Which explains why thiopentone is great for inducing anesthesia, but terrible for maintaining it for a long surgery.
Exactly. The fat compartment slowly saturates, and then the drug concentration in the blood starts to rise again. The duration of its main effect is determined by redistribution, not true elimination.
Okay. We've successfully navigated the drug's absorption and its distribution path. Now we enter the body's ultimate chemical factory, biotransformation or metabolism, the M in ADME.
And its core purpose, really, as a survival mechanism, is to chemically change fat-soluble, persistent compounds into water-soluble, polar compounds that can be flushed out.
It's like a hazmat crew.
That's a great way to think about it. If the drug remained lipid-soluble, the kidneys would just keep reabsorbing it in the tubules, and it would stay in your system almost indefinitely. Metabolism is the process that converts these fat-loving substances into water-loving metabolites, ready for the drain.
And metabolism isn't just a one-way street to inactivation. You mentioned there are 3 potential outcomes.
Right. The most common outcome is inactivation, where the drug is converted into an inactive metabolite. That's number 1.
Simple.
Number 2 is sometimes we generate an active metabolite. This means the parent drug and the resulting chemical compound both contribute to the overall therapeutic effect. Diazepam, for instance, is metabolized into oxazepam, which is also an active tranquilizer.
Yeah, the third one.
The third outcome is crucial, the activation of an inactive prodrug.
Prodrugs are a very clever pharmacological strategy. Why are they used?
Prodrugs are designed to be entirely inactive when you take them. They require the body's metabolic machinery to convert them into the active drug. And they serve several purposes. Sometimes it improves absorption, like we saw with levodopa.
Right.
Other times it might be to mask a bitter taste or to reduce local side effects by only activating the drug once it reaches the liver. Examples include enalapril, which becomes the active blood pressure drug enalaprilat, or various chemotherapy agents that are only activated inside tumor cells.
So let's detail the actual chemical processes. They're broadly grouped into 2 phases, phase 1 and phase 2.
Phase I reactions are the preparatory non-synthetic step. They primarily involve oxidation, reduction, or hydrolysis. The goal is simple: introduce or unmask a functional group, usually a hydroxyl group or a carboxyl group, COOH.
Then that makes the drug a little more polar.
A little more polar, and it provides a chemical handle for the second phase.
Then we have phase 2 reactions, the synthetic or conjugation step.
This is the definitive cleanup. Phase 2 takes a drug or its slightly modified phase-I metabolite, and it attaches a large, endogenous, highly water-soluble molecule to it, a conjugate.
Like what?
This could be glucuronic acid, sulfate, glycine, or acetate. This conjugation reaction drastically increases the drug's polarity and its molecular weight, making it highly water-soluble and unable to cross back over membranes. It's locked in for excretion.
And clinically, which one is most important?
Glucuronidation. The addition of glucuronic acid is by far the most important conjugation reaction.
Okay, so the majority of the heavy lifting in phase I, especially those complex oxidation reactions, is carried out by the microsomal enzyme system in the liver.
Right. And at the heart of this system is the cytochrome P450, or CYP, family of isoenzymes.
This CYP system is basically the body's central detoxification unit.
It truly is. It's located in the smooth endoplasmic reticulum of your liver cells, and its sheer variety is why medication response is so individualized. We really have to highlight the two major isoforms that are the source of most clinical headaches.
Let's meet the big two.
First, CYP3A45. This is the powerhouse. It metabolizes approximately 50% of all therapeutic drugs.
Half of all drugs.
Roughly half. And it's not just in the liver, it's also in the intestinal wall and the kidney, making it crucial for that first-pass metabolism we talked about. Its substrates are everything from losartan for blood pressure to warfarin. If you are taking two drugs, there is a 1 in 2 chance that CYP3A45 is handling both of them.
And the second major player.
That would be CYP2D6. It handles about 20% of drugs, including many antidepressants, beta blockers like metoprolol, and the pain reliever codeine. And this isoform is perhaps the most notorious for its genetic variability.
Genetic polymorphism, what does that mean for a patient?
It means that genetically, some individuals are defined as poor metabolizers for CYP2D6. They have severely reduced enzyme activity, so standard drug doses can accumulate rapidly, leading to toxic levels.
And the opposite can happen too.
The opposite can happen. Some people are ultra-rapid metabolizers. Their enzymes work overtime, clearing the drug so fast that a standard dose is entirely ineffective. Codeine is a great example.
How so?
Codeine is a prodrug. It needs CYP2D6 to convert it into active morphine. An ultra-rapid metabolizer might experience dangerous toxicity after a normal dose because they convert too much, too fast. But a poor metabolizer would get zero pain relief because they can't activate it at all.
This natural variability, combined with external factors, makes this whole enzyme system ground zero for dangerous drug interactions through enzyme modulation.
Right. And we can categorize these interactions into two types. First, enzyme inhibition.
Something is blocking the enzyme.
Certain drugs actively inhibit the function of these metabolizing enzymes. If you take an inhibitor, it ties up the enzyme, preventing it from working on other drugs that rely on it for clearance.
Can you give us a powerful example of an inhibitor interaction?
Classic examples are the antibiotic erythromycin, the antifungal ketoconazole, and even common things like cimetidine, an old heartburn drug, or antidepressants like fluoxetine, and of course the most famous non-pharmaceutical inhibitor.
Grapefruit juice.
Grapefruit juice. It contains compounds that irreversibly inhibit CYP3A4 in the gut wall.
And the consequence of this inhibition?
A dramatic decrease in the metabolism of the other drug, leading to a significant increase in its plasma concentration and a dangerous potential for toxicity. If you inhibit the enzyme that clears a heart medication, that medication accumulates, potentially causing cardiac arrest.
The second type of interaction is the reverse, microsomal enzyme induction.
Induction is when a substance increases the actual synthesis of new CYP enzymes over time. It's like telling the liver to build more chemical processing plants.
And what are the inducers?
Common ones are anticonvulsants like phenobarbital and carbamazepine, and the potent antibiotic rifampin.
Is there a non-drug inducer that people encounter every day?
Polycyclic hydrocarbons. These are found in high concentrations in cigarette smoke and in charbroiled or heavily barbecued meat. They are powerful inducers of the CYP1A enzymes, which can speed up the clearance of many other drugs.
The consequences of induction are just as complex, and they're often delayed.
They are. The most frequent consequence is a reduced drug effect because the drug is cleared too quickly. The classic clinical example is the failure of oral contraceptives when a patient starts taking rifampin, the powerful enzyme inducer.
Just chews through the contraceptive hormones too fast.
It ramps up their metabolism, eliminating them before they can be effective.
But sometimes increased metabolism can lead to increased toxicity. That sounds counterintuitive.
It does. But this happens when the drug itself is safe, but one of its metabolites is highly toxic. Take paracetamol, or acetaminophen. At high doses, increased induction, say, from chronic alcohol consumption, can speed up the formation of a toxic metabolite, which then overwhelms the body's detoxification pathways, potentially leading to fatal liver damage.
And you also mentioned something called autoinduction, where a drug speeds up its own clearance.
Carbamazepine is the classic example. When a patient starts this anticonvulsant, its half-life might be 36 hours. But after 2 weeks of steady dosing, the drug has induced the very enzymes that metabolize it, and its half-life can shorten to just 18 hours.
So the doctor has to anticipate this and adjust the dose.
They have to anticipate this autoinduction and increase the maintenance dose over time just to maintain the same therapeutic level.
Finally, let's explicitly circle back to first-pass metabolism in this context.
As we mentioned, this is the metabolism that happens before the drug reaches systemic circulation, primarily in the liver and the gut wall. Drugs absorbed orally go straight to the liver via the portal vein, so the liver enzymes get the first crack at them.
And for drugs with high first-pass metabolism, like the beta blocker propranolol or morphine, this means the oral bioavailability is shockingly low.
It is. Sometimes only 20 or 30% of the drug actually makes it into the general circulation. And this is why the oral dosage of these drugs has to be dramatically higher than the equivalent dose given by injection. The liver is just a massive and efficient filter, making the oral route highly inefficient for these specific molecules.
Okay, we've absorbed it, we've mapped its path, and we've chemically altered it. We've arrived at the final destination. Excretion. The E. The systemic removal of the drug and its water-soluble metabolites from the body.
And the urinary route is the undisputed king of excretion. The kidney handles 3 distinct processes to get this job done. The first is glomerular filtration.
This is basically a size filter, right?
Yes, exactly. The glomerulus allows small molecules to pass into the renal tubule, but critically, it only filters the free drug. Remember our equilibrium. The plasma protein-bound drug is too large to pass through, so it's temporarily spared elimination.
The second step, active tubular secretion, sounds much more dynamic.
This is the powerhouse step. Secretion mechanisms in the tubules actively and efficiently pump drug molecules out of the blood and into the tubule fluid. And here's the key difference from filtration.
What's that?
These mechanisms remove both the free drug and the protein-bound drug.
So it's much more efficient.
Highly efficient. The proteins release the drug as the free concentration drops, allowing the entire dose to be actively pumped out.
This active secretion site is famous for one of the oldest drug interactions we know of, the probenecid-penicillin interaction.
That's a classic example of competitive inhibition at the transporter level. Penicillin is rapidly eliminated via this active tubular secretion. Probenecid, an anti-gout medication, competes fiercely for the exact same organic acid transporter.
So if you give them together,
you tie up the transporter with probenecid, which slows down the excretion of penicillin. Historically, during wartime when penicillin was scarce, doctors would give probenecid just to prolong the antibiotics action, essentially recycling the expensive drug within the body.
And the final step is passive tubular reabsorption.
As the fluid moves down the tubule, water is reabsorbed back into the body, which concentrates all the waste products, including our drug. Now, if the drug is still lipid-soluble and non-ionized at the urine's pH, it will simply diffuse back across the tubular membrane into the blood.
It re-enters the body.
It tries to. So we can manipulate this final step through ion trapping, but in reverse. Since reabsorption depends on the drug being non-ionized, we can change the urine pH to ensure the drug stays ionized. For example, if a patient is poisoned with an acidic drug like a barbiturate, we can make the urine more alkaline. We raise the pH.
And that traps the acidic drug in the urine.
It forces the acidic drug to become highly ionized in the now basic urine, trapping it in the tubule fluid, preventing reabsorption and speeding up its excretion.
Beyond the urine, what are the other key exit routes?
Feces is a big one. It accounts for the fraction of the drug that was never absorbed, plus any drugs that were excreted via bile. Once in the gut from the bile duct, a drug can sometimes be reabsorbed back into the circulation.
That's enterohepatic cycling.
Exactly. It can significantly prolong a drug's stay in the body, which is important for certain antibiotics like erythromycin.
And the less common routes?
Volatile substances, like general anesthetics, are primarily eliminated via exhaled air. Their elimination depends entirely on the concentration gradient between the blood and the air in your lungs. And finally, we have to mention milk for nursing infants.
Right.
Milk is generally slightly more acidic than plasma, meaning basic drugs can concentrate a little more in breast milk due to this pH difference, though most transfer is still just passive diffusion.
Okay, moving to the quantitative side of this, let's define clearance, CL.
Clearance is the ultimate measure of the body's efficiency at elimination. It's defined as the theoretical volume of plasma that is completely cleared of a drug per unit of time. It's a rate metric, not an amount metric.
And its clinical significance is huge.
It is essential for determining a rational dosage regimen. If you know the target steady-state concentration you want to achieve, and you know the patient's clearance rate, you can calculate the exact rate at which the drug needs to be given to maintain that concentration. Clearance is the foundation of precise dosing.
This leads us into the fundamental rules of removal. The kinetics of elimination. Most drugs follow first-order kinetics.
First order is simple. The rate of elimination is directly proportional to the concentration of the drug present. So if you have 100 units and the rate is 10 units per hour, when you drop to 50 units, the rate drops to 5 units per hour. The percentage removed per unit time is constant.
Which means the clearance and half-life are also constant.
Exactly. This is how the vast majority of drugs behave.
But then we have the exceptions, the dangerous ones, that follow zero-order, nonlinear kinetics.
This happens when the elimination processes, the enzymes, the transporters, become saturated because the drug concentration is too high. It's like a factory running at maximum capacity.
Yeah.
Once it's saturated, the rate of elimination becomes constant, and it's independent of concentration.
What's the consequence of that saturation?
Potentially disaster. Since the rate of removal can't increase, even a small increase in the dose can lead to a disproportionately massive spike in the plasma concentration. The safety margin just disappears.
And a classic example of this is?
The everyday example is ethanol, alcohol. Your body can only process about 1 drink per hour, regardless of how quickly you consume it. Other examples are high doses of phenytoin and, sometimes, the process of aspirin elimination.
The ultimate clinical metric that comes from all this is the plasma half-life.
The half-life is simply the time it takes for the plasma concentration to reduce to half of its original value. It's directly related to both the volume of distribution and the clearance. And while it varies wildly among drugs, penicillin G is 30 minutes, digoxin is 40 hours. It's the cornerstone of dosage scheduling.
And the rule of thumb based on that half-life.
That elimination is considered nearly complete after about 4 to 5 half-lives. And inversely, this same rule dictates the time required to build up the drug in the system to a therapeutic level.
Which brings us to repeated drug administration and dosing regimens. When a patient starts a long-term medication, the concentration builds up until the input, the dose, exactly balances the elimination, the clearance. This is the plateau principle, or steady-state concentration. CSS.
And just as it takes 4 to 5 half-lives for the drug to be eliminated, it takes 4 to 5 half-lives to reach that steady state concentration. So if a drug has a short half-life, say 3 hours, we give it frequently, maybe every 6 hours, to maintain the concentration within that therapeutic window and minimize the fluctuation.
And sometimes we simply cannot wait 4 or 5 half-lives for the effect to kick in, especially in an emergency.
That's when we use a loading dose. This is a single, large dose given right at the start to bypass that slow accumulation phase and quickly achieve the therapeutic CFS. If a patient is having a dangerous cardiac arrhythmia, you give a loading dose of lidocaine immediately.
You can't wait 15 hours for the body to naturally build it up.
Absolutely not.
And once that plateau is established, we switch to the maintenance dose.
The maintenance dose is the dose given repeatedly to maintain that CS by continually balancing the drug input with the calculated rate of elimination. And that maintenance dose must be perfectly tailored to the patient's individual clearance rate to prevent either accumulation or inadequate treatment.
Finally, let's look at how pharmacology works to achieve the prolongation of drug action to make life simply for the patient.
The simplest method is manipulating the formulation. Sustained release tablets, they often contain tiny pellets or spancels, are engineered to release the active substance slowly over 4 to 10 hours. This reduces how many times you have to take a pill and prevents those dangerous peak and trough concentration swings.
Then there are the physical deposits.
Yes, parenteral or injected deposits. Drugs can be formulated into oil solutions or small pellets that are placed under the skin or in a muscle, and they slowly leach the drug out over months or even years.
This is great for patient compliance.
Hugely effective. Think of the progestin-impregnated IUD, which offers protection for up to 5 years.
And finally, the future of targeted delivery.
This involves novel systems that aim to localize the drug to the exact site where it's needed. The concept of liposomes is fascinating here. They are these tiny bilamellar nanovesicles that encapsulate the drug.
Trojan horses.
Exactly. When they're injected, these Trojan horses are selectively taken up by the body's cleanup cells, the reticuloendothelial cells, which are in the liver, the spleen, and critically in many malignant cancerous cells. This selective delivery allows us to use highly toxic drugs like amphotericin B for a systemic fungal infection, but target the drug away from healthy tissues, drastically reducing systemic toxicity. Hashtag conclusion and final thought. So we've traced the molecule's complete journey: absorption, distribution, biotransformation, and excretion. These 4 quantitative processes, ADME, they're not just academic footnotes. They are the governing laws that dictate the clinical effectiveness, the safety profile, and the necessity of every single dosing schedule ever created.
And that's the real takeaway for you. Understanding this journey transforms your relationship with your medication. Your dose is a precise, calculated response to your body's estimated clearance rate, which is, in turn, affected by your genetics,
Those CYP enzymes,
your diet,
grapefruit juice, or a fatty meal.
and any other drug inducers or inhibitors you might be taking.
And it all connects back to the power of that simple rule. It takes 4 to 5 half-lives to reach a therapeutic steady-state concentration.
Let's end on that provocative thought, connecting kinetics back to clinical urgency. We discussed that phenobarbital, historically used to manage seizures, has a notoriously long half-life, roughly 90 hours. If a patient is starting on that drug and it takes 4 to 5 half-lives for their body to stabilize, that's nearly 2 weeks of waiting, during which time they're unprotected and potentially still suffering from seizures. That time lag is clinically unacceptable.
Completely.
So we know the mathematical problem. The question for you to think about is, what is the single practical step doctors must take right at the beginning of that 2-week accumulation period to bridge that safety gap?
And that necessity is the perfect illustration of why the loading dose is non-negotiable for drugs with long half-lives. It is a pharmacokinetic cheat code. It proves that a doctor's knowledge of ADME is often the difference between life-threatening risk and safe, immediate therapeutic relief.
Thanks for diving deep with us on this microscopic chemical journey. We'll see you next time.